good evening in India and good morning in USA, afternoon in some European country, and good evening in other part of the world. I'm Dr. Rajesh Mishra. We have gathered here, all the stalwarts have gathered here to discuss in last 8 or 9 months what went wrong in managing COVID-19 because it has taken away lots of energy, lots of our resources for managing, and still we are nowhere. So we know that when this COVID came, we did not really know what is going to happen. We learned with a lot of things we knew that we are doing wrong. We learned with the cases and subsequently we tried to correct ourselves. So today we are going to take this discussion on this way that what could have been done better in last and what in future, what should be doing to get this better. So with this, uh, about this pandemic. My first discussion, and I will try to all this. I'll request all the speakers to be precise and try to limit their words in one and a half minutes. So most of us can comment on that thing. So, Dr. Sumit Ray, I had read an article from you that we did not learn anything from our past mistakes or past pandemics. Can you just quickly elaborate here what went wrong in understanding this pandemic? Sumit.
Thanks, Rajesh. I wouldn't say that we didn't learn anything, but we have to realize that a pandemic is as much a social phenomena as a biological one, and it has its cannot be separated from its historical, geographic, economic, and socio-cultural context. So it's not just what we do as doctors that matters, but it also matters what politicians do, where the geography of the country that we live in, all these things matter. The history of past pandemics, all these are correlated, and the socioeconomic status, the public health systems that we have, the social security systems that we have. So what happened probably in this pandemic, some of the things is that at this certain moment, there were certain leaders in the world who were, I would say at best grandstanders, at worst authoritarian, and also megalomaniacal, along with very good leaders in the world. But what happened in the process is that some of the work which should have been done by clinicians and researchers got taken over by certain grandstanding politicians, and certain therapies, certain treatments like HCQ, convalescent plasma, etc., and many some others got promoted by politicians, political leaders rather than scientists. That's one aspect. Second aspect, I do not blame them also directly, because it was so much panic there that the politicians had to show that they were doing something at least. Okay, and in that context also, there were in the whole process, what we also did in the process of trying to do something within courts, some places the lockdowns were so severe, and some places there were so many denialists that on one hand you have the example of certain countries in South America, I won't name the countries, where the denial of the pandemic caused a lot of deaths. And in some countries in Asia or South Asia, we have such severe lockdown too early in the phase that probably it ended up in severe economic deprivation, forcing people to leave cities to go into back to their villages, immense amount of hunger. And, the data is coming out that there is hunger has increased and these were actually seen in the Black Plague, 13th to 16th century. We exactly saw these patterns when people were forced and locked down strictly at that time, so many centuries back. Then they ran to their villages from the cities. And in the process, one was they suffered because of that. Second, they took the infections back to the villages in the Black Plague. And the same thing tended to happen. The positives, I think, the positives that in the larger scale, and I'm not talking about specific treatments, is that there was international cooperation, much more than ever before. And an understanding, I think, a realization, I hope, that public health measures, social security are going to be the biggest things which will help us in these pandemic situations. And in that, I feel, I don't want pick up any specific, but probably the NHS, not only because of the quality of care, along with many other public health systems and health systems, but particularly because they kept their head down, kept calm, did research in the right way without trying to find out, let's do this, let's do that. It was a very planned, the recovery trial was very planned, and that gave us the initial information where we could really direct our resources to what we should do. And that is.
Sumit, I will stop you here. I was just want to go to Dr. Mitch Levy for the rest of the comment, if you don't mind. Just
Sure.
Dr. Mitch Levy, sir. Dr. Mitch Levy, sir.
Yes, thanks, Rajesh.
Yeah.
So,
yeah, I have a question, a very specific question. It is said, okay. I hope it will not offend you. It is said that Americans do not do mistakes second time.
Do not what?
It is said that Americans do not repeat same mistake second time. So what we have learned from here, that if we face same pandemic, or what we have learned from this pandemic, that we will not repeat these mistakes second time. Or you will not.
Okay. Yeah. First of all, the most important thing is, I truly hope we never have an idiot for a president again. And so to me, that is the most important way not to repeat the mistakes of this pandemic. Okay. And as Dr. Ray said very nicely, politics superseded science, and that was the biggest mistake.
Okay. Dr. Ashish Balla. Dr. Ashish Balla.
Yes.
Dr. Balla.
Yes.
If you have to say in one word, what did you learn from this pandemic for India? What will you implement?
There are very many positives. The kind of the commitment the healthcare workers have shown, the kind of commitment the politicians have shown. Forget the lockdown. Whatever the lockdown did was give us some time to build up our capacity. We at PGI, in those 1 month, we set up a 300-bedded standalone hospital, which was there, but was occupied by other people. We got our processes working. So that gave us some time. If that had not happened, we would not have got that time. Obviously, it happened at a great loss to the economy, but it saved quite a lot of lives at that time. Sumit said that it was too early, but I think it could have been phased in a proper manner, where that's a big lesson which could be learned. What I think we have learned is that India has got a capability, and both the government sector and the private sector can stand up to any kind of a disaster and deliver. That is something which I think in this pandemic we have learned. We've learned to join hands. We've learned to share information amongst ourselves with the international bodies, and we've learned to take a step forward.
Okay, thank you. Now, very quickly, I come to the purpose for what we have come here. This is the case: a 60-year-old male, controlled diabetic and hypertensive on OHA and ACE inhibitor, 2-day history of low-grade fever, 2 bouts, 100-degree, throat pain, body ache, and sneezing. RT-PCR done, which showed positive, CT value of 18, 18, 19. SpO2 is maintained 95%. Routine report done was shows 16% lymphocyte, 1% eosinophil, and CRP 20, D-dimer 400, ferritin 300, IL-6 45. He was advised by his physician to stay at home. My question goes first to Dr. Lopa. Do you agree that this patient should be at home or in hospital?
Yeah, thank you, Dr. Rajesh. It's great to be here. No doubt, I will suggest this patient to be in home quarantine.
Okay, thank you. Srinivas?
Yeah, Rajesh. Yes, Rajesh.
What is your advice for this patient?
Look, on the face of it, he is a little high-risk guy. He is an elderly guy. He's probably diabetic, although we are saying it's controlled diabetes, but the vascular changes of diabetes do happen even if your diabetes is well controlled. He's a hypertensive on 8 milliliters, and he's not, maybe his saturations are okay at this point of time, but at least I would not probably risk him at home. He should be in an observed isolation in a observation center or a COVID care center, if not in an intensive, in a hospital.
Okay, he should be observed. Even wherever he should be under
Yeah.
strict
He should
observation.
be observation. He should be under surveillance and observation.
Okay. Sandeep Kontur is joined. Dr. Sandeep. Sandeep, have you joined? No. Ashish sir, Dr. Balla, your point of view. You want to keep the patient at home or in quarantine or in hospital, somewhere observation? Very quick comment.
If the saturation is 95% and this patient has got somebody who can monitor the saturation at home, and if there is a healthcare facility where this patient can be brought in, preferably in an elderly patient, what we've realized is that if you put them in an isolation alone, taking care of themselves, it's nursing care is a little bit of an issue. So I would say that initially, yes, but if I would prefer to do a 6-minute walk test in this patient. If this 6-minute walk test is showing a positive report, that is, there is a significant fall, more than 3% in the SpO2, I would definitely get the patient into the hospital under observation.
So borderline conclusion from all of three you are that you want wherever he is, he should be under strict observation and clinical monitoring. That's one thing. And 6-minute walk test, if it is positive, should go to hospital and monitor his SpO2 strictly. Okay, Rumta sir, a very quick question. A lot of this patient have lymphopenia and eosinopenia. Does it carry any meaning to this patient, Dr. Rumta sir?
Yeah, lymphopenia, worse the lymphopenia, worse is the patient. That is, what we think about. But, my one single point diagnostic and decision making that affects my decision making is oxygen saturation. My separating line is oxygen saturation 96 or above or less. If it is less than 96, he has to be in the hospital under observation.
Okay.
So I won't do any other investigation. Whatever has been done, X-ray probably yes, but not the other tests.
Okay. Subal, are you there? Subal?
Rajesh. Yes, Rajesh.
What is
Yeah.
your comment on severity of lymphopenia and eosinopenia and with the clinical correlation of the patient?
See, I agree with what Dr. Rungta has said. Lymphopenia is also just one of the markers of immune suppression, especially in the face of the COVID patients. So definitely lesser is the count of lymphopenia, definitely the chances of the severity will be high. Although these patients really need to be monitored closely in the hospital. That's the only thing I would put it, especially with high risk, in this case, with a high risk of diabetes, he needs to be in the hospital.
Okay.
I just said that,
Yeah.
Rajiv,
Yeah.
this is Sandeep.
Yes, Sandeep.
Now, yeah. Now, the only thing is, going by the resource scarcity in the major hospitals, probably at this point in time, I would not like to, get him to the hospital straight away. I would definitely recommend that this patient should be monitored, closely, and I mean, with the caveat that whenever we see any further deterioration in a symptom or drop in saturation with any mobility, then he should be immediately brought to the hospital. So this is my comment. And as far as
So I take your point that even at home, but he should be under strict monitoring. There should be someone to be monitor his oxygen level at least, and when it drops, when he becomes symptomatic, he should be brought. Fairly okay. We agree with that. Pradeep Rangappa, quickly.
Yes, Rajesh, regarding lymphopenia.
Yeah, I just want to comment how much importance you give in your practice to the lymphopenia and eosinopenia. It's last
I
comment.
think, yeah, I concur with Subal and Rumta sir, what they've said. See, lymphopenia is one aspect, but NLR ratio is what increasingly has been identified as a good prognostic marker, Rajesh. And if you have to subscribe to the evidence, I think 18 is the cutoff because the Lancet trial said that 18 was an independent risk factor for bad outcome, NLR ratio. So the higher the NLR ratio, worse is the outcome. And we have also seen in our practice that the patients who are very sick generally do have a very high INR, and sequential increase in NLR does corroborate with the ongoing progression of the disease, Rajesh. Over to you, Rajesh.
Okay, thank you. Carlos. Dr. Carlos.
Yeah,
Yeah.
sure.
Carlos, what will you do in your country?
In our country, as we're talking now about leukemia, yeah?
Yeah, we can listen, hear you. Please go ahead.
Yeah. As we know, leukemia is a marker.
Your voice cracking. Your voice cracking, Carlos.
That to be worse. But that's not a criteria to hospitalize the patient or to us, because as you know, low income and middle income countries, we don't have enough beds at the hospital, so we have to keep the most patient as possible at home. So that's the reason we don't take that is not really important to us. Actually, I think almost nobody here in Latin America use this marker to guide the treatment of the patient.
Okay. Dr. Chawla, sir. Dr. Rajesh Chawla.
Yes, Rajesh.
Very specific question to you. Will you advise CT scan, HRCT thorax to this patient at this stage?
I do not get CT scan in every patient. You know, this way you end up getting a CT scan, but most of the patients nowadays, it is so prevalent that everybody comes with a CT scan. But I do not get a CT scan right in the beginning. I would wait for it if there is a sign of deterioration or maybe end of the first week.
Okay. So you don't want, so
unless there is a complication, unless patient is on oxygen, if patient like this, I would not get a CT thorax.
Okay, very good. So I will go one by one. Lot of medicine by our physician, general physician, and whosoever practice is being prescribed nowadays for at home. So this patient was at home, and if I show the prescription, all these medicine has been prescribed. So I go to the Reena. Reena.
Thanks, Rajesh.
Very specific question to you. Do you use flavirapir, or do you think flavirapir does any good to the patient?
We don't use flavirapir. We don't use it here, and we don't think there's any benefit. And out of that whole list you've put in,
no. Reena, I'm not putting whole list to you. A very quick question, very specific question. So anybody, I'm just asking, anybody in the panel want to use flavirapir for any patient at home? I think I take answer no.
Yes,
so
Rajesh.
I
would use it. I would use it.
Okay, Rahul, please tell me. Tell us. Yes.
Rajesh, there is some benefit from you. So if you have to use something, you need to use an antiviral agent. Okay. There aren't many antiviral agents which have shown some amount of viral clearance. Favipiravir is one of them which have basically shown some viral clearance. Now the whole thing about rest of the drugs which we are using in COVID, it is true for favipiravir as well. Use it within the first 3 to 4 days. Start it as early as you can. If you are already crossed 4th, 5th day, probably I would not use it as well. I have not used it rather. But if the patient comes to me within first 3 to 4 days of symptoms with a positive report, I would not hesitate to use favipiravir.
Okay, Deepak, you were saying something?
Yeah, I agree with Dr. Rahul Pandit. We are also using, but in very early phase.
Reena, what is your thought on other heart drug, antiretroviral drug? A lot of antiretroviral has been suggested.
So initially there was discussion on lopinavir, ritonavir, but there is no evidence post-recovery that there is any benefit. So we don't use it.
Ashish, very quickly, I want your comment about flavirapir in heart. Are you using or not?
Oh, and I won't use it because why do you have to give something?
But sir, I want very straight answer, no explanation. We understood. I mean, there is a division. And Dr. Dhruv is here. Dr. Dhruv has joined the panel. No, okay. So now I will go to the Dr. Rungta sir. Your thought on doxycycline and ivermectin?
Absolutely no.
Okay.
So no ivermectin, no doxycycline, no favipiravir.
Okay. Thank you.
No role.
Okay. Kapil, Dr. Kapil Jirpe.
Yes.
Your thought on vitamin C, D, and at-home dexamethasone.
Rajesh, before that, just I will take 10 seconds to manage this patient at home. The problem is this is a borderline high-risk patient, and unfortunately, our people never follow the strict instruction of the bed rest and this thing. So I will little hesitate to keep the home quarantine, as Srinivas said, because these are the high risk patients. Their chances are always deterioration, and people will not tend to follow the strictly the doctor's advice. And most of them, whole family members were affected. So who will take care of whom? That was a further issue. And second, coming to these drugs, I never use Flavipira in home quarantine patients or doxycycline or any other drugs. Might be if the patient insists for some medication for their mental satisfaction. Please understand using the word. Sometimes we have to boost their mental this thing that the doctor is prescribing some drugs, vitamin C or vitamin D, maybe in some patients, but otherwise we try to educate them and give them the assurance that nothing will happen. Please follow the strict instruction of twice a day pulse oximetry saturation, bed rest, good hydration, and inform if there is a fever, dyspnea, or chest pain. So this is what we need to have a daily video conferencing twice a day with the families and with the home quarantine patient, and just educate them. That is more important rather than any all of these fancy drugs. Thank you.
Dr. Mitch Levy, sir. Dr. Mitch Levy?
Yep, I'm here.
In this list, what you use at home?
None of them.
I have given the last option also to you.
Say that again?
I have given the last option also, none.
Yeah, I would not use any of them. There are no data to support the use of any of the drugs that are on this list.
So I want one person to reply, if except Flavirapir, what I got. Anybody use any of other drug? Kapil has replied in the list, and if they have any explanation to say, otherwise I go to next slide.
So
Otherwise,
Rajesh, can I just add that?
Yeah, Rina.
I would. So paracetamol for symptomatic relief if you have myalgia, headache, fever, maybe. So it's just for symptomatic. And I just want to add that dexamethasone used in somebody who has normal oxygen saturation is actually detrimental. And there's clinical based evidence to that. And I know a lot of family practitioners at home, even in our country, use dexamethasone. So that is a total no-no.
Yeah, that's what I wanted to hear from you, that we should not giving dexamethasone if oxygen saturation is not low.
Rajesh, I have one question, especially with GIT involvement in COVID. What is the role of doxycycline and ivermectin?
No role.
No role.
Definitely no role at all.
I just no role. Yeah, Rajesh, can I just ask one question?
Please.
Yeah. Now it's all right to say that I will not use any of these drugs, but when you listen to a top infectious disease expert like Dr. Fauci, when he says that he's taking vitamin C, vitamin D as supplements, what is the message he's conveying to the general public?
So I'm on the I was appointed by Dr. Fauci to the NIH guidelines panel, and I want to clarify what you just said, because there's a difference between taking vitamin supplements versus using therapeutic doses of vitamin C or vitamin D for the treatment of COVID-19. Tony Fauci's never suggested that, ever.
Dr. Dhruv has just joined. Dr. Dhruv, welcome. Very quick comment from you, that what medicine you will use at home.
I don't give up. You see, am I audible?
Yeah, you're audible, sir. Very much.
Yeah. I do not prescribe anything except for some amount of vitamin supplementation, no antivirals, nothing, except because most of the time the diagnosis is made on 4th and 5th day. And if you look at the data, there is no evidence to suggest any of these medicines as of today are preventing the immune responsiveness. Give them adequate hydration, rest, keep track of the things, and thank you very much. That's all I say.
Thank you, sir. Dr. Mitch Levy, very quickly. I don't know you will like this question or not, but your outgoing president took this medicine and said, I'm feeling all right. So what is your comment on this in giving?
I've already made my comment on my outgoing president. And so I don't have to repeat the fact that he's an idiot, but I do think that the monoclonal antibodies, they are authorized for use. We, as our guidelines panel, say they should not be considered standard of care. The data are suggestive that they might be of benefit pre-hospitalization. I would consider offering it to a patient, but they're not cheap.
Okay, thank you. Dr. Quirino. Dr. Quirino? Dr. Quirino? Dr. Quirino?
He's mute.
Dr. Quirino?
He's mute,
Yes.
Rajesh.
Dr. Kurino,
Hello.
what is your comment on this neutralizing antibody cocktail in early phase?
Yes, I think I want just to go back about the previous question. This disease, we must remember that is a very quick disease. So the changing of the disease is just in 2-3 days. What I don't see that is not take in any consideration the disseminated intravascular coagulation. So my experience of 500 intensive care beds patients is to give a precox amount of this drug. First of all, because can avoid a lot of trouble, especially minimizing the cytokine storm. Secondly, we forget that heparins a very strong anti-inflammatory property, and so can help in a very good way. We have many scans of people that have only 1 day of disease, very pouchy symptomatic, and they have micro aggregation in his pulmonary. So I think that it's more important to talk about this than to talk about the drug against COVID. We know that we have not the just drug against COVID. We went from Ebola in my institution, that is the National Institution for Infectious Disease, that is very important. And we compare all our treatment with the Ebola patients that have a very high degree of mortality. And we find that no drugs is really effective on COVID, unfortunately. Why? Because all the states put all the effort on vaccine. And why this decision? I like very much the first talk, because he underlined how all the institutions fail to manage this problem. Because if we put all the money to find, as the WHO has decided after the Ebola pandemic, to find the right drug to treat these viruses, probably we are not still with so much death. But we prefer to choose the street of the vaccine. Why? Because vaccine is the way to become a leader in politics, in hegemony in the world, not for help the patients, because we know that we take a lot of time, and we need so many doses to resolve this problem with the vaccine, and we don't know. I work in the European Commission, and the European Commission has signed an agreement with Pfizer that for the next 4 years, they don't take care of any side effects. That means that all the side effects of the new vaccine will be covered by the national states. That means we pay for the consequence of this attitude. So I think that we must, if we want to consider how to get out from this tragedy, we must understand that all our institution has completely failed because they don't make a good work. And now they want that the doctors that have paid a very high tribute in death and the nurses can say it's our fault because you have a lack in therapy, you misunderstanding the ventilation in COVID, you think that was an RDS, is not an RDS as we have shown, but our doctor have only one fault. We haven't done so many autopsies to understand the real state of the disease. In all the world, we have in our institution the highest number of autopsies. And for this, we were able to understand that the RDS is not the real RDS. We need a mild ventilation, and we understand that we have a disseminated intravascular coagulation that was the main problem of the disease. And we understand also that the virus attacking...
Dr. Quirino, these points we are going to have come in further slide because we just want to progress. We are summarizing everything. So my question again remains same. Are you going to use this in early phase, this neutralizing antibody cocktail or not?
Yes.
Yes. Dr. Chawla. Dr. Chawla. Dr. Rajesh Chawla. Dr. Chawla, sir, he's muted.
Okay. I think he's muted.
Okay, no problem. So now on 7th day,
Rajesh, your answer to this question, I was listening very carefully, is in terms of it. You see, when we are using monoclonal antibodies in the first phase, it's practically like neutralizing as an antiviral.
Yeah.
And dominantly it is from that purpose as the passive immunization is being done.
Yeah.
So it is the same principle on which we are working. Now we need to have a good trial data to show whether it is effective or not. That is one part. And secondly, the same way people are using in the similar fashion the convalescent plasma therapy. Now we need to know how much is the need and requirement of the doses to neutralize the virus. So if we can do it within first 1 week, nothing to beat it. Therefore, let the data come up and then probably answer will be there because quite a large number of these drugs have been emergency use authorization 1. Secondly, I heard you asking that question also about antiretroviral drugs. I think we have missed the bus. And one of the major reasons has been whenever people have used lopinavir in MERS and all, they combined it with ribavirin. And somewhere we try to use it all and then do it. You look at today also, we are using remdesivir in the first week in comorbidities. Has it stopped the difference and later on in terms of having immune complications which are happening on? I think that part we need to look at it. Probably we are thinking that everything is a black and a white. Biology does not work like that.
Okay, thank you. Now on 7th day, this patient has one episode of fever, shivering, cough, fall in saturation to 90 degree, feeling of chest tightness. Patient was rushed to ER with 26 respiratory rate, 80 saturation, and 100 heart rate. Dr. Deepak Govil, what will you do here?
So with 90 saturation, first of all, first thing is to put oxygen therapy. Okay. So I would like to put the oxygen first, maybe by the simple face mask or the prongs. Look at the SpO2. If it is picking up, it's okay. If it's not picking up, then I'll maybe go for high flow nasal cannula.
Okay. Dr. Chawla has joined us. Dr. Chawla?
Yes.
What will you do here? This patient has come to you in ER.
You know, this patient has now the oxygen has dropped. First of all, he has to be admitted. And a patient like this, I would, most of the time, I send the repeat markers, get a HRCT done, and then start this patient on remdesivir and steroids. That's the usual. And if there is a procalcitonin is high, I do start the antibiotics also.
Okay. Dr. Nitin, you are there? Or you are still late?
Hello. Just joined. Sorry.
What will you do in this case in your ER?
Okay. But,
did you hear the first thing?
No.
Was a high risk patient by the home quarantine. Now he has become breathless and rushed to your ER. Now what will you doing here?
Okay. So basically, obviously, basic management, give some oxygen.
What they have told, you will do anything extra? You want to add something?
I'm sorry, I missed the first bit, but realistically, the key is we have to give antibiotics because you don't know whether this is added bacterial infection while you're waiting for calcitonin coming. And then again, the big controversy is, do you actually start remdesivir? And that's locally, we are still giving remdesivir if we think we've caught them early enough, but actually there is not enough evidence. So it's a bit difficult here.
Okay. What anything special about investigation you will advise for this patient? Apart from RT-PCR and anything specific you want to look to that?
Well, locally, what we are doing as standard is, apart from the chest X-ray, we do ultrasound as standard, point of care ultrasound at the bedside, because that is quick, easy. We have ultrasound available in the emergency department, so you can do it in 5 minutes. And that will very often give you classic COVID features. And you can also see whether there is something else, fluid overload, extra B lines, pleural effusion. That is quick and easy. And then if they don't start improving, then we start thinking about whether we go in for a CT scan. But also, typically, if a patient like this comes in and within a couple of hours, if they are on more than 50% oxygen through face mask, we start talking about enrolling them to the recovery RS trial. So we do not provide high flow or CPAP to anyone without thinking about the recovery RS trial, because that's the best way of finding out actually what modality works best.
Okay, Nitin, anybody else who wants to think twice for giving remdesivir in this patient, or who doesn't want to give remdesivir? Anybody? So everybody will give remdesivir except Nitin.
Yeah. You see, the question is, you need to again to look at it.
Yeah.
What is the reason for the problem in this patient?
Yeah.
And that's why I agree with my colleague from a friend from Italy, that we need to have a good data of histopathology or autopsies. If you see it in autopsy studies, everywhere you are seeing a virus plus inflammation. Therefore, you need to reduce the load of a virus. This is the best antiviral as of now available, though I rate it as 6 on 10, not more than that. It's a question, it's a viral sepsis, which has led to the unleash the immune responses. Therefore, the data is coming up now where you use a combination of steroids plus remdesivir is far more effective than alone. Therefore, I think there is a reasonable amount that we will.
Rakesh.
Can I make a comment, Rajesh? Sumit here.
Yeah, Sumit.
Yeah, so the worry is, I agree that if an antiviral would be the best if it worked. The problem with remdesivir, it's not that I'm not using. The worry with remdesivir is with what? Respiratory viral infections. Actually, the perfect time to give the remdesivir or any antiviral is actually before the symptoms start. And unfortunately, that's the problem with all respiratory viral infections. For heart, etc., they are slow growing viruses, slow replicating viruses, rather, I would say. That's a different ball game altogether. For HIV, for hepatitis C, hepatitis B, it's a different ball game. They are slow replicating viruses where adding the antiviral at a certain point will check it. But with respiratory viruses, with influenza also, we have seen the same thing. That's already too late when the symptoms come up and we are intervening at that point of time. Having said that, in the early phase, I am also still using, and the evidence at this point of time, if you see the Act 1 trial and the Solidarity trial, is that only in the subgroup who are getting small amounts of oxygen are the only ones who have had a shortening of length of stay. Those not getting oxygen and those on high support, it's pretty useless.
You know, Rajesh.
Sumit, I will go by.
Yeah. You know, the other drug which can be considered in this stage is a baricitinib, which we have the recent data also.
I will come to that.
You see, Rajesh, what Sumit said theoretically looks pretty good, and by and large, we agree. We had discussions also a couple of times.
Yeah.
Answer is very clear what we are looking at. No drug is going to give you, even in the severe sepsis, if you look at the data in the trials, in the septic shock, you have a 40% mortality. Here you are coming with the person concerned who has got a viral pneumonia, or you have basically immune response. We are seeing it in the second week. No, that is why steroids are so effective in it. But at the same time, we are seeing now that there are people who are having even a late surge. People are having a symptom and they're again showing and growing viruses where it has been done up to second, third, fourth week. Therefore, I think till we have a better antiviral drug with us, we need to look into it. Therefore, you have to do a two-pronged trial where you go early. Obviously, the people who have a small amount of oxygen, they will recover. We are looking everything in terms of their outcome, if it can, in terms of mortality. Obviously, that's a very important part. But as far as doing it in a critical care setting, it may not be as simple as it looks like.
Okay, sir. Thank you.
Rajesh, can I make a comment?
Yeah. Reena, quick comment and then I go to
So what I would do is I would give the patient oxygen, give them dexamethasone and prone the patient. I think by now he's probably day 7, he's probably day 9, 8, 9, 10 into his symptoms. I don't believe remdesivir would work.
Yeah,
and he's probably going into the autoimmune condition.
Dr. Rajesh, I will add to
one by one. Sandeep and then Prashant. Sandeep.
Rajesh, I will agree with Dr. Reena because I'm not sure it's actually day 7 or day 8 or day 9, because at this point in time there is no data which suggests that remdesivir is going to be shortening the hospital stay or reducing the requirements of oxygen.
Okay.
I think Rajesh, I have a very strong Rajesh, I have just one point, just a minute.
Yeah.
You see, what they are all saying is, I agree, this is the data which has come up. But unfortunately, we are all speaking the language which is written in the papers. You look at the autopsy data, please. You look at it. The number of, not a single autopsy study has shown the absence of virus in your alveoli. Therefore, please look at it. Reduce antigenemia. This unleashing is something to do with the host responses, but at the same time, you look at the data which we have from the McCoy in the animal in the Covaxin trial. They're all dealing with it and how the antibodies are working against it. Therefore, let's not be, it is something, I put it as such, that people for 20 years kept on saying NIV reduces the rate of intubation. Nobody said it reduces the rate of mechanical ventilation. Therefore, let's go by it. Under what context, where you have done it. Most of the study you have started remdesivir at 12 days and other ones. They're also in subgroup of patients you are doing it. Therefore, let us not, biology is non-linear. Let's look at that way. It may work at somewhere. We are all looking that it is all linear. So let's be open to it. And sometimes people anecdotally are even using second courses later on, and where they're finding consistent, especially immunocompromised people. Now we are going up to 2 months. Therefore, please be open and yes, take a case-to-case decision.
I think you have to base it on the data. I don't think this has to be based on opinion. And I feel strongly that that's what motivates people to just do anything. So yes, of course you have to pay attention to biology, but if there are no trials or data to support it, we just simply shouldn't be doing it.
Okay.
Again,
please. I'll just Prashant and then Rahul and then I conclude. Prashant, what is your comment?
Dr. Mishra, this is a very important, and it's a difficult decision making, and we all most of the time will start remdesivir in this patient. But yes, I agree with Dr. Sumit. The evidence is actually when you started before the symptoms. If you have missed that burst, the chances of having a good outcome or those early recovery will be less. The steroid will be a more important key in this particular group of patient when you are already having a symptom and requirement of an oxygen. So if it is requiring oxygen,
I'm coming to you.
Steroid,
Rajesh, can I come in?
Yeah.
Rajesh, we are sitting here to clear the doubts. We are not sitting here to confuse the audience. This patient is home quarantine. When we say the symptom, before symptom arises, do you mean the before everybody commented that there should not be any drug to be prescribed? And when patient had a symptom and arrived to the hospital, now we are debating whether to give antiviral because the symptoms, once the symptom arises, it should not be drug. I think we should go by what we did in last 9 months and what we got the response. I am saying the 7 days symptoms in 1 or 2 days, he's a candidate for antiviral and steroids, because we need to come to the conclusion. We are only talking on the evidence, and the practice is completely different. Please.
Okay. Rahul, you comment.
I agree with you, Kapil.
Awake proning oxygen, dexamethasone, remdesivir.
Okay. Look,
I want to say something.
Yeah. Please. Quick, and then I comment. Who wants to say something?
Sheila wanted to say something.
Yeah, Sheila, quickly.
I wanted to say something. I know our practices are very different from what's in the literature. Nevertheless, the benefit is seen in the first 72 hours and definitely not in the mechanically ventilated group. So a lot of times what happens is people are still, what I observe is people are still giving remdesivir in mechanically ventilated patients. And like Dr. Ray rightly said, in the subgroup of patients, there was a benefit when it was started early. So in severe COVID. So in this patient, definitely I would consider starting remdesivir. Now, the timing is a little plus minus. So maybe if the patient has severe COVID, I would still consider remdesivir. But giving every patient remdesivir across the board, like is happening, I think we have to do this with caution. So definitely in non-ventilated patients only, and early within the first 72 hours, and in severe COVID.
Okay.
Rajesh, may I come in?
Sir, last comment and then I go
30 seconds.
Yes, sir.
You know, I'm just, agreeing with Kapil. We are here to clear confusions.
Yeah.
The NIH CDC protocol is the most credible protocol till date. And most of us are not sure what to do when.
Yeah.
And the credible direction and the protocol observed and directed by NIH and CDC are in hospitalized patient with hypoxia, when they need oxygen, we give them dexamethasone plus remdesivir plus low molecular weight heparin and prone them consciously. And there are, lots of queries and questions, confusions, ifs and buts attached to it.
Sir, I agree on both sides.
And, and the duration of remdesivir is not important when it started. It will start only when the patient is hospitalized, not at home. It has to continue for 5 days. And if the patient is not improving, the Act 2 trial has shown that even it may be continued for another 5 days. I think Mitch would agree with me.
Sir, one thing, but I can say, apart from evidence also, and apart that when patients get critical on ventilator, most of the time remdesivir doesn't help. That is correct. To give or not to give, I leave to the audience.
Nobody is sure, Rajesh, whether it helps or it doesn't help.
That's why I'm concluding. Early use remdesivir as early when oxygen start dropping early. Try to give. The patient should not become so sick that he needs ventilation. In between is the time where remdesivir can help. Neither before and neither after. That's what the conclusion is. Very quickly, I go to the next question to Dr. Chawla. What is your interpretation for cough in COVID patient? Clinical, because it's a very important and most important sign which is being missed to assess some of the patients who are getting sick. I feel so. That's what your comment.
Yeah, because many of the patients around the 7th day, when they're going into cytokine storm, is many of these patients start with cough and then they get breathless. Yeah. And some of them will get breathless first. But it is an important symptom and we should be very cautious in evaluating these patients who start getting cough.
Okay, thank you. Now coming to the slides. This patient was shifted on 50-liter oxygen. On
Rajesh, again, there is a problem with the cough. Quite a few of these patients have people, if the character of the cough changes, in addition to that you have to be worried, because right from the beginning, because of upper respiratory, some of the people, especially asthmatics or COPD, may be having a cough which is there. Therefore, when the character of the cough changes, that is as important as a new coming cough at that point of time.
Okay, sir. Now this patient is shifted to ward, admitted on 15-liter oxygen, maybe under high, somebody would like to keep in high dependency as per their availability. On an RBM, 96% saturation, taken to room. Little settle, awake proning, otherwise he has poor compliance. Remdesivir is started, methylprednisolone was started in this hospital. I'm not saying I started, I wanted to clear. And this is what the practice is being done. 125 milligram methylprednisolone, enoxaparin is started, ivermectin, doxy, vitamin C be cleared, ceftriaxone is started, insulin is started, Sepsivac and antibiotic started. Sheila, coming to you very quickly.
Yeah.
Dr. Sheila.
Yeah.
First 2 slides. Where would you like to keep this patient and what about awake proning?
Yeah, so
very specific answer.
Definitely in a monitored area, because this patient is oxygen dependent, so it's extremely important to keep him and monitor regularly because this patient may rapidly deteriorate. Regarding awake proning, there are only awake proning has not shown any benefit. It's shown oxygenation, improvement in oxygenation. However, no improvement in outcome. So a lot of us are practicing it. Both awake proning has shown benefit both in COVID as well as non-COVID in terms of improving oxygenation. So now there is currently the COVID-prone trial, which is a randomized controlled trial looking at proning, awake proning versus not proning. The benefit is seen in mechanically ventilated patients. So definitely a lot of people would try this. The concerns really are that sometimes it could delay your tracheal intubation, right? So a lot of times it gives you a false sense of security. You've prone this patient and you may actually delay tracheal intubation. So we have to be very vigilant. Even if we're doing it, there's no harm really. It's a simple intervention and the patient can prone himself and the families can monitor them. But if we do it, we have to be extremely vigilant, and there's no evidence for any improvement in outcomes, only improvement in vaccination.
Thank you. Excellent. Excellent, Sila. Dr. Yatin Mehta, sir, is there? Have you joined? Dr. Mehta? Dr. Carlos. Carlos.
Yeah, sure.
Carlos, will you start remdesivir in this patient and methylprednisolone or something else? Two questions. Will you start remdesivir or not? And will you give methylprednisolone or any other steroid?
We don't have remdesivir in Ecuador. I haven't used it at all. So we don't use methylprednisolone. We only use dexamethasone 8 milligrams per day during the most cases 10 days, or when the patient needs no more than oxygen, no more than 6 liters per minute. Yeah. Yeah. That's it.
Okay, thank you. Lopa, Dr. Lopa.
Yes.
Low molecular weight heparin. When will you start and what dose?
Yeah. In our country, am I audible?
Yeah, you're audible.
In our country, when the patient is D-dimer is more than 1000, then we use in normal dose, that is the 1 milligram per kg. And if it's the D-dimer is higher than 1000, then we use it like BD. But it depends upon the patient's condition. And we use when the patient in our government protocol, we use the patient when it is when the patient is in a hospital.
Okay, thank
not
you.
At home.
Dr. Subal, we have discussed those medicines which not to be given. I want to clear again to the audience that oxygen is okay. Awake proning, if it is feasible and comfortable. If patient is not tolerating, then no. Remdesivir, yes. Methylprednisolone, high dose, no. If at all you want to give up to maximum 32 milligram, otherwise preferably dexamethasone 8 milligram as per trial. Enoxaparin as per D-dimer. We have already discussed that ivermectin, doxycycline, vitamin C, and vitamin D has not to be given. Antibiotic as protocol. Now, insulin, high insulin is one of the things which creates a lot of problem because of the COVID itself and because of the steroid. Rahul Pandit, what is your take on managing insulin in COVID patient? Rahul, you are there? Rahul? Hello? Subal?
Yeah. Yes, Rajesh.
Yeah. Question goes to you. I will ask Rahul if he comes back. What is your take about two other things? That is Sepsivac and starting any antibiotic in this patient?
See, antibiotic we are giving, especially if the patient has fever, we are usually giving them ceftriaxone or piperacillin tazobactam into those patients who have got COVID pneumonias.
So they will come with fever. All these COVID patients may have.
Yeah, so either we start them either with all those who are into the intensive care units, we are using piperacillin tazobactam, or those who are in the wards, we are giving ceftriaxone. We are giving them, and we are combining them with azithromycin into these patients. And as far as the sugar control is concerned, we are giving them insulin and they're trying to keep the sugars between 150 and 170. As far as Sepsivac is concerned, yes, definitely we have used immunomodulators. It is one of the new Mycobacterium W immunomodulator which has got an TLR agonist effect. Definitely, it is a very potent interleukin 6 inhibitor, which has recently been approved by the DCGI on compassionate basis to be considered for use as a adjuvant therapy in cytokine storm. And since it's a very potent interleukin 6 inhibitor, and one of the trials which was done in gram-negative septicemia for these patients, which was approved by DCGI, and even Dhruv has is also been done one trial in Rohtak where it has shown beneficial effect. And recently there's also been a study which is being published in Lung India, which is being published by Inderpal Sehgal, where definitely it's shown that definitely the CRP levels and the interleukin 6 levels have gone down. In that was a very short case based report, but the recent study which has been conducted into PGI Chandigarh has just been submitted for publication, and it will soon be coming out. So in case if you use it early in the course of action, especially if then it can be considered as a adjuvant form of therapy. Although yes, definitely we are still using tocilizumab, even if the trials have not been.
I'll come to that, Subal. So I will come to that.
Yeah.
Dr. Ashish Balla. Dr. Balla?
Yes.
Your comment on controlling blood sugar, what all you do, because this is very important. Most of these patients, if sugar is not controlled, can go in unrecognized decay and can even have other complications like MI, stroke, nuclear infection. So your take, how do you control sugar in this patient? It's very important.
See, there are two very interesting things which we have observed, and I think we will be starting a study very soon on that. One is the fact that very many patients who've never been diagnosed diabetic, when they come with COVID, and we get their HbA1c and we find that they are 13, 14. So it's that people have been diabetics, never knew it, developed COVID, and were detected. That's point number one. Number two, whenever we are using steroids, their sugars go haywire. Stress hyperglycemia is very well known, right? And the second thing is the use of high dose steroids, would also make the sugar control bad. So what we use is we give a basal bolus. We are using Lantus basal bolus, and then we give multiple subcutaneous injections. In patients who have very high sugars, we put them in ICU and we put them on infusions, because in them it becomes very difficult to control the sugar surges. But what we have seen is, if you do not kind of titrate your insulin properly in these patients, many of them, when we were having very high number of cases, and when there were some mistakes in giving the insulin and the relationship to the food which these people were taking, they were going into hypoglycemia. Those hypoglycemia were being causing more damage. So you need to be very, very careful. And if what we have now started using is insulin infusion, if the sugars are not being controlled, in addition to all the other patients where we've been using a long acting basal bolus with multiple subcutaneous injections. We have some observations where people where we couldn't get basal bolus long acting, and we've used NPH. So we're starting a study on NPH insulin versus basal bolus, and with our endocrinology department, and we'll be coming out with those
okay.
Results.
Okay. Srinivas, and Srinivas, quickly one comment from you. Any role? Do you use metformin?
No, Rajesh.
Pradeep, do you find any role of metformin in this patient?
No, Rajesh, not in ICU, Rajesh. We use only insulin infusions.
Okay, perfect. So, because I asked this question especially because there was some thought and some some theories spreading that one can use metformin to have better healing process or some better healing in lung. But I think anybody uses metformin for that purpose in sick patient? Anybody?
Rajesh, can I come in?
Yeah, sir.
If the patient is a known diabetic and has been on metformin for a long time and is not in ICU,
yeah,
he's in the ward, he requires just observation, and he requires maybe minimal oxygen. There we use metformin. We sometimes in addition to the long-acting basal bolus insulin also. But other than that, if the patient is critically ill and the sugars are very high, it's insulin infusion.
Okay, thank you. Sandeep,
yeah.
This is what about the prone position is, awake proning is. So
Yes.
first thing, do you practice awake proning? And if it is, then what is your protocol?
See, we do practice awake proning, especially in ambulatory patients. So, especially in ambulatory patients. So we, give them because they may not be able to, go for 12 hours, 16 hours proning at a time. So we generally, whenever they are comfortable, we do side-to-side proning as well as prone, total proning, side-to-side positioning and proning. So this is what we practice, especially in ambulatory patients only.
Okay. There's only
Even on
problem,
patients,
only problem.
Even on patients NIV and high flow nasal, we have done.
Okay. Only problem with the proning is the obese patient do not has very poor compliance. Elderly female has very poor compliance, and most of the time people do not find it very comfortable to be awake prone. So I don't know. So how should we interpret? But anyway, if patient is comfortable and not getting restless, one can try for this trial. Now, 8 day, 12 hours after admission, this patient become restless, breathless, and saturation drops to 85% on 15 liter NRBM. Shifted to ICU, put on high flow nasal cannula, 60 liter is maintaining 95%. She was here in ICU, given tocilizumab, conversion plasma. Ilnastatin also started in this, meropenem, linezolid, and voriconazole started. Patient remained breathless. Dr. Mitch Levy, sir. Dr. Mitch Levy.
Yep.
What would you have done here in this patient? What was done? I don't want to ask. What would you have done here in this patient?
So, so it's 8 days. She's received, I think, remdesivir and now is on steroids, although the dose of steroids is a little higher than we would normally use. She may or may not be on an insulin drip, and she now looks like she needs, she's on 15 liters per minute and 85% SpO2.
Yeah.
Yes, we routinely use up to 40 liters a minute.
Yeah.
So I would certainly increase her. Oh, I see she's on 60.
So we have put on HFNC, 60 liter. She's on 60 liter HFNC, maintaining 95%.
Okay, and tell me what you're asking, Rajesh. Are you asking if I would use the anti-IL-6 antibody?
Now here on 60 liter, will you use tocilizumab here in this patient? Tocilizumab?
Yeah. So I was on the DSMB for 2 RCTs for IL-6 inhibitors, one in Europe with Sanofi and the other one in the United States with Regeneron, and they were both negative. Okay. And so I know that there's recently reports of remap COVID with perhaps positive results. We haven't seen the data yet, which has come out of the University of Pittsburgh. I personally think there's no role for IL-6 inhibitors in the treatment of COVID-19. And I think more importantly, I'm also a non-believer in the term cytokine storm. And if you look at the IL-6 levels that have been reported in the literature, mainly from Wuhan and a few other trials, a few other centers early on, the IL-6 levels that have been reported in the COVID-19 patients are actually lower than what's been reported in the past in septic patients. So I strongly do not believe that there's a role for IL-6 inhibitors.
Okay, sir, thank you. Dr. Curino, will you use tocilizumab here in this patient or not at all? Dr. Curino?
Sorry?
Dr. Curino, will you use tocilizumab in this patient in this stage or later or earlier?
I think that we decide our therapy in base of our findings, physiological, pathophysiological findings of our patients. So I agree with the previous talk about the strictly control of glycemia. We have an automatic control of this problem, and we use insulin.
No, I'm talking about tocilizumab. Will you use tocilizumab?
Sorry.
Will you use tocilizumab in this patient in this stage right now?
I don't understand your question.
Sir, this patient is in ICU on HFNC, maintaining saturation. will you use tocilizumab in this patient or not?
IL-6 inhibitors.
IL-6 inhibitor, tocilizumab.
Yes, we use, of course, but we need to consider one problem, that these patients has a greater compliance, more than 50 up to 80. So the compliance is more severe in these patients compared with that of RDS. And secondly, if the X-ray shows characteristic peripheral density of the lung, so we start the development, the oxygen is not enough, and the amount of oxygen don't take in consideration the lung vasoplegia, that is the final result of the vasodilatation. That means the oxygen is in the upper part of the lung and the blood is down. So there is this is the basis, the main basis of hypoxia. And if we don't consider this, the problem is not how much oxygen we are delivering, but to prevent and to modify this state. In other words, gravity dependent versus verso perfusion created a mismatch that is the main cause of hypoxia.
Dr. Prashant, will you use TOSI?
Yeah, thank you, Dr. Rajesh. Give me 2 minutes to come to this. This is a very important discussion, and I think other than the steroids, the major part of the studies have been done now on tocilizumab. Though RCTs are negative, there are a good number of equivalent observational studies which have found some amount of benefit. And now with REMAP CAP study, which is going to be published soon, and with the preliminary report, there is some sort of a benefit. So you have to understand, basically, it's a dysregulated immune response, and it's not a single pathway which is get dysregulated. It's the innate immune response which produces hyperinflammation, while there is a defective B cell response causing less antibodies, and that's why some patients may require antivirals, while there is a defective T cell response. So all the pathways may be involved. We really don't know which patient will have which pathway get involved, or they may be combination of these pathways. So in some subset of patients, there may be an issue of hyperinflammation. And in our experience, what we found is to identify these patients by doing an IL-6 level. When they are having a higher requirement of oxygen or there is a sudden deterioration, we get an IL-6 level. If it is above 100, which is for us is 10 times above the upper limit of normal, then we do consider 2 doses of tocilizumab, one at 8 milligram per kilogram, and then repeat at after 12 hours, again a dose of 8 milligram. We have found that in some subset of patients, we can actually prevent them going on invasive mechanical ventilation. But to say this, with the use of timely steroids now with the second wave, the number of patients requiring this is very, very low. I have not used it for some time just because we are using 8 milligram of dexamethasone and remdesivir on a time. And most of these patients do not get IL-6 level now more than 50 or more than 60 now. So yes, in this patient have IL-6 high.
Sumit, I'll come to you. Sumit, I'll come to you. Just give me 2 minutes. Rahul Pandit. Rahul Pandit, your comment. Rahul, you are there? Rahul is not there? Okay. Dr. Chawla, your quick comment.
We have used it in the beginning, but last about 4 months, I have not used even in a single patient. I somehow feel it may help few patients in overcoming oxygenation, like Dr. Nasa said, but the secondary infection is very high, and we have totally stopped it. And I don't find that it helps because the rate of secondary infections have gone down in our ICU.
Okay.
Rajesh, can I come in?
Rajesh? Yeah, Kapil.
Rajesh, regarding this particular TOSI, initially when there was a very literature was not aware, initially out of 20 or 18 patients, we had a mortality. But when we learned the right timing and the right patient, in selective patients, if you use them before they go on a high flow or before they go on an invasive intubation ventilation prediction, this dossier works, and out of remaining 30, we have almost got 24 who have survived. So I think the timing of the patient, selection of the patient, and the dose, we use the single dose. Initial phase we use the double dose, but now we are using the single dose 400 OD. And most of the patients in later phase of the disease, probably it is a better understanding of the disease process, help us to select the right patient and the right timing and the right dose to avoid the second infection.
Okay.
Rajesh, can I make a comment?
Yeah, Rina.
Yeah, so I want to echo what Dr. Kapil said. So there have been negative studies, but there has been a study that was published yesterday in the New England, the Impactor study. And the difference between the Impactor study and the Covactor study, the Covactor was negative. It included patients that were on mechanical ventilation or NIV, so very severely ill patients. The Impactor study included patients pre-ventilation, pre-CPAP, pre-BiPAP. And what they found is giving tocilizumab to these patients reduced the incidence to mechanical ventilation by 45% compared to placebo. So I think there is a role for tocilizumab if we get the right patient. So these are patients who are deteriorating, whose oxygen requirements are going up, whose CRPs are going up, but you also have to have a negative PCT. You've got to make sure that there's no other intercurrent infection. The second thing is your dose. When you double dose, when you give 2 doses, your risk of infection goes way high. So in our institution, we were just giving the 1 single dose at 8 milligrams per kilo, and we found that our infection rate went down. Impactor also showed that the incidence of infections between the tocilizumab group and the placebo group, there was no difference between the 2 groups. So it's the dosing and the timing of the tocilizumab, which is very important. And we are finding very good data and outcome. And we're also waiting for the REMCAP study. I think that will seal the deal for tocilizumab.
Okay, that's great. Sumit,
Yeah.
Sir, I'll give you time. I'll give you time. Let Sumit comment, then you comment. Yeah, Sumit.
So I'm as much a student of history as of medicine. So I'll go back to the same debates happened in sepsis. Go to 1980s, 1990s, anti-inflammatory therapy for sepsis. High dose steroids, anti-TNF alpha, toll-like receptor antagonist suppression, all of them failed. Okay. And as Dr. Levy said, Mitch Levy said, the cytokine levels, the IL-6 levels, I have done a study, ICMR project, the IL-6 levels in COVID is way lower than bacterial sepsis. Okay. And when you suppress the immune response, I also have a problem with the cytokine storm theory, and the same arguments have happened and the same arguments failed for sepsis. And I think for COVID, it will fail because immune suppression, what IL-6 tocilizumab does is immune suppression. Immune suppression is going to be counterproductive. As far as the Impactor trial is concerned, no disrespect to anybody, but the mortality in the placebo arm was 8% and tocilizumab arm was 10%. Does a trial of severe COVID, which has a mortality of 8% in the placebo arm, really required the tocilizumab? I mean, that's a big question. Second, unfortunately, the Impactor trial, even the data collection, the data analysis, the planning, everything, the last part, the investigators were there, but all these elements, the data analysis, everything was done by the industry. There is a huge conflict of interest if that is done. There is a huge problem with it. And unfortunately, the another thing we have learned from the COVID pandemic is that some of the top journals in medicine got compromised by publishing studies which should not have been published, among many.
Okay. Yes, Dr. Dhruv sir, quickly.
See, we participated in a tocilizumab trial, and it has now been, data has been analyzed and sent to one of the Lancets for publication. Let's see what happens. So till the results come, I can't comment upon it. But I think what is very important is it's a right selection of a patient. It's a very small subset of people who have a hyperacute syndrome, which is happening. That is only one small subset where it does work. Rest probably, again, it will bring down, it can only guide you. It can only tell you, suppose if somebody deteriorates over 24 to 48 hours, it will work. Yes, it may. On the other hand, if somebody is smoldering, it will not work. Therefore, I do agree with what Sumit said, and I do agree also with Dr. Rina. We are not using more than 1 doses because we need to understand why we are doing. Idea is to break the inflammation and then let the steroids take over. I think that's how it is there. So if you can say it, more of it, Again, I don't, because this is not a point of discussion and I have to leave after this. That's why I just intervene. We are now going and planning up a trial of methylprednisolone of 250 milligram in the beginning when those patients coming with a very severe hypoxemia, and along with the All-India shoot and other places, so that we know what we are doing is right or wrong. So probably some amount of a basal bolus it is there. Let's be very clear about it. When the recovery trial started and they looked at it, 8 milligrams of it, 6 milligrams of dexamethasone, they were not aware what they are looking at. Now you are looking 6 milligram for 40 kg, you are looking 6 milligram for 100 kg. I think somewhere we need to re-look at it. What it has shown very clearly is steroids are beneficial.
Okay.
So I think it's an important issue which probably you will be needing and looking at individual basis and the profiling of the disease.
Very quickly, in the same slide, I want a quick comment about the convalescent plasma. Dr. Bhalla has left, so I go to the Dr. Deepak Govil and Srinivas for their comment on convalescent plasma. Deepak. Srinivas?
Yeah, Rajesh. That's again a tricky question, something which people had a lot of hopes on based on the early evidence, and then slowly we were told that it's not going to work. I'm not fully convinced that it's a completely redundant therapeutic modality.
So you use or not? Srinivas, you use or not?
I use it. I use it, Rajesh, but
what is the dose you give and when?
See, what I understood by the use of plasma is.
You are not visible. Your video is off. Okay, no problem.
I think just one. Okay, so what I have understood or what I have learned from using plasma is, once a patient actually graduates into invasive mechanical ventilation or he develops hemodynamic instability, if that is the point of your initiation of convalescent plasma therapy, you are more likely to fail. So if your patient is actually graduating from a face mask to a high flow nasal cannula, or you feel he needs non-invasive ventilation after having tried with conventional oxygen therapy, if that is the point you are trying convalescent plasma, my results have been good. I can't say with what p-value and what confidence interval, but it seems to be working in a good subset of patients. However, your donor selection is the key, is also what I have understood from this experience. You need to take in those who have appropriate titers of antibodies. So if you use the right donor and you use it at the right time, probably I can't vouch and say it will save lives, but definitely if your endpoint is prevention of invasive ventilation, I think it's done a good job for me, at least in my practice.
Okay. Deepak, you are there? Dr. Deepak?
Yes, I am here.
What about comment about convalescent plasma? Quick.
No, we are using convalescent plasma. Till now, I have used convalescent plasma in more than 300 patients.
Okay.
So it is before going to mechanical ventilation. Once person is on mechanical ventilation, then I don't think anything is working.
Okay, that's great. Very quick and very crisp comment and very crisp.
One part only I will like to put upon the recipients.
Yeah.
Now, what is happening is when these patients are coming up, please do check it. What we do and we're giving it is whether they have antibodies or not. If they're negative only, then we are taking up the patient for plasma, not otherwise.
Okay, Sheila, Dr. Sheila, you are there? Dr. Sheila.
Yes, right, Rajesh, I'm going to taking your leave and thank you so much.
Yes, thank you, sir. Sheila, when will you start any antibiotic in this patient? And what will be your antibiotic of choice?
Right. So the previous speakers have talked about antibiotics. I would really not start antibiotics on this patient. I would only start for specific indications. This is a viral infection. So in a patient where the procalcitonin is high and I'm suspecting some other bacterial infection, like would happen after several days in the ICU on a ventilator with lines, etc. In these cases, specifically after sending cultures, I would like to start antibiotics. I would not routinely start piperacillin, tazobactam, and any antibiotic on this patient from day one, just because they're in the ICU or they're intubated or they have lines in. So it would be in specific cases where I'm suspecting some bacterial infection.
Dr. Rungta, sir, your comment on antibiotic in this patient. Dr. Rungta, sir.
Okay. Antibiotics, should be, I agree fully with Sheila.
Okay.
Antibiotics have no role to play unless you are absolutely sure whether either you grow an organism or you have good evidence in form of patient has secondary infection, has high procal. Otherwise, use of antibiotics is absolutely, as we have been talking for ages.
Okay. Thank you. Dr. Chawla, you were talking about baricitinib plus remdesivir. Have you used this and what is the result?
I have used in 2 patients and fortunately both of them have survived. So it is too little number to really say that it is effective.
Okay.
And they have already received 10 days and both of them did not go on to ventilator.
Okay.
And they are on low flow oxygen.
Okay.
So both of them have worked.
Pradeep, any experience on baricitinib?
No, Rajesh, I have not used baricitinib, but I have just read the manuscript of this trial that has come out. It seems to be compelling, but in this trial, we have to bear in mind that they have not used steroids, Rajesh, as a standard of care. Right now, we are using steroids as a standard of care for all the patients on oxygen. So in this particular trial that has come out, steroids was not routinely given in patients. So they have compared a group with remdesivir in one arm and remdesivir with baricitinib. So we have passed that situation. Now steroid is a standard of care. So I do not know for sure whether we would be subscribing to baricitinib at this point of time. But what this trial did show was they did compare steroids and no steroids, where steroids were given for other reasons, where patients were on steroids for some other reasons. And they found risk of infection was high in the steroid group as compared to the non-steroid group, Rajesh.
Okay. Nitin, are you there?
Yes. Hi.
Your comment on this combination.
This is, yeah, I haven't used this. It's not formally approved for use at our site. But again, like previous speakers, I've read the trial with interest, and I've also read the NIH recommendations based on that trial. And the NIH recommendations, if I remember them correctly, I read them 3 or 4 days ago, said that this combination is only recommended when you cannot give steroids. And I have not seen a COVID patient where we couldn't give steroids. So basically, based on current recommendations, this actually is a pretty redundant and very expensive combination.
Okay. Dr. Mitch Levy, sir, what your comment about this drug, baricitinib?
Yeah, so I would echo what everyone has said. As I mentioned, I am on the NIH panel, and our recommendation is that because the trial actually did not test patients who were on steroids, I would suggest that as long as steroids are available to us, it should be the standard of care, and I wouldn't use it.
Okay, thank you. So now progressing to this patient, when will you give an IV in this patient, non-invasive ventilation? Keeping all these issues in mind, patient is still breathless. Dr. Lopa, will you try to consider give an IV here?
First of all, I will check the patient's check the patient of this PO2 and FiO2 ratio, and if it's not possible, then I will check the SPO2 and ratio of FiO2.
Patient is breathless, saturation is 95%. On an IV, on high frequency 60 liter.
Okay, then if the patients, if patient is NRBM can tolerate and the saturation is I didn't listen you.
Yeah, we can listen you. Please go ahead. Will you give an IV trial or not in this patient, non-invasive ventilation?
No, if a patient is 95% saturation, then I will not go for an IV.
Okay. And Dr. Chawla, what is your take? When will you consider?
First of all, I want to know what was the FiO2 on HFNAC. One of the problem which
HFNC, it was 95%, which is maximum given, and 60 liter oxygen. Still is breathless and 95%.
And how much was the FiO2 on your HFNAC?
95%.
95%. So you were giving very high oxygen to this patient.
Yeah.
This is a problem which I have seen over the years. I've been closely following a lot of patients who are not ventilated. India, either they are given HFNAC or they are given NIV with 80%, 90% for a long period of time, and they are ventilated late and they don't do well. somehow I think we should ventilate the way we ventilate any ARDS patient. We should go for invasive ventilation when there is an indication. And previously, I also used to continue the HFNAC and NIV for a long time on 70% or 80% FiO2. But what I have seen is that these patients land up with more pulmonary fibrosis. And now we have changed our policy, like we ventilate any ARDS patient. And what I'm finding is not only they come off the ventilator faster, the fibrosis is because you ventilate with lung protective strategy and prone them, and the fibrosis is also less. So
Rajesh, can I make a comment?
we ventilate these patients
Rajesh, can
quite
I
early.
make a comment too?
Yeah.
Dr. Sheila, after Dr.
Rajesh,
Sheila.
yeah.
And then Prashant.
Yeah, I think I agree completely with Dr. Chawla. Now here, this is a patient who's already on high flow nasal cannula oxygen. You're giving maximum support and patient is not maintaining saturation. NIV, most people consider only if there is a mixed kind of respiratory failure and not when high flow nasal cannula oxygen fails. And a lot of these times intubating, the decision to intubate would be purely clinical, based on how, the clinical signs of respiratory failure, what is the saturation of the patient, is the patient in distress? And we all know that a lot of these patients, are quite hypoxemic. If you look at their blood gases, or even if you look at some of the CT scans, you want to intubate them very early. And this was the mistake we made very early in the beginning of COVID, intubating patients very early, looking at their blood gases, seeing that they were severely hypoxemic. And we realized that if the patient is not symptomatic and they're maintaining their saturations and they're comfortable, then we could keep them on high flow nasal cannula oxygen. So I would not switch to NIV when there is failure of high flow nasal cannula oxygen. And my specific indication to use NIV would be more in a mixed respiratory failure and not upfront. I would prefer high flow before.
Excellent. Very clear. Thank you. Prashant, your
Yeah,
comment.
I think Dr. Rajesh, thank you. Dr. Sheila made a very good point. We should not use them as a sequential. What we tend to do it is we use HFNO first, and when we see the patient is failing or is still not getting better with HFNO, then we are switching to non-invasive. Rather, I should say word CPAP rather than non-invasive, because NIV is only patient with mixed respiratory failure. If it's a CPAP which has to be given, it has to be given either HFNO or CPAP. If one of them fails, this is the patient which requires invasive mechanical ventilation. Please do not delay invasive mechanical ventilation in these patients.
Rajesh, can I make a comment? Rahul here.
Yeah, Rahul, please,
Yeah.
Rahul.
Look, Rajesh, I think a lot of our therapies, which have been sort of talked about, are looking at whether we can avoid intubation or not, and that's absolutely wrong. I completely agree with Dr. Chawla. We need to go back to our ARDSNet protocols. We need to basically look at the time when we intubate these patients and intubate them at the right time. Don't sort of flog them on with high flows for long hours, with high FiO2 for long hours. And if we do that correctly, I am pretty certain the outcomes are better. And I have been doing that right from day one. We've not changed our protocol since the 23rd of March, when we started taking in the first COVID patients in our hospital.
Okay, that's great. That's great. So message is very clear that if either of the things fail, do not try alternate rather than intubate early, rather than intubating late.
Rajesh, I would like to comment. See, what happened, like this particular case, if you see, this doctor is a victim of the so many trials and so many opinions and so many discussions. So what is happening? The HFNO was highly abused or misused, I will say. Second thing, whenever you are using any therapy, whether it is high flow or BiPAP, you need to give certain time, at least 12 hours, 24 hours. You cannot jump on within few hours. So I would like to know how many hours he was on a high flow before jumping to the intubation. And second thing, what I completely agree, there should not be the sequential choice of the these devices. If the patient needs invasive ventilation, looking at his clinical work of breathing, his respiratory rate, and the oxygen saturation, you need to go ahead with the intubation and ventilation. So,
Excellent. I agree with you. Dr. Carlos.
Actually, in my hospital,
Dr. Carlos, I have a very specific question to you. What precaution you take when you intubate this patient? How will you intubate this patient? If you have decided.
Sorry, can you repeat, please?
If you have decided to intubate this patient, what precaution you will take for intubating this patient? It is decided that this patient has to be intubated. What precaution you will take?
What?
Precaution.
What safety
Because
measures would you put in, Carlos, when you were trying to intubate these patients? What would be your safety measures to protect yourself and the environment? That's the question.
to preserve ourselves
Yeah.
Yes.
at this time, date 8, mask, field,
Okay.
and no more than that.
Okay. Rahul, anything specific in protection?
Look, we have not been using these shields. We have been very specific with our mask and shield, eye protection. Yeah, yeah. And video laryngoscope. We all try to do all our intubations with a video laryngoscope.
Yeah, anything specific?
Ajit, can I comment?
Sheila, yeah, Sheila, you want to take
Yeah.
anything specific about
So
intubation?
in the beginning, there were a lot of these intubation boxes and people were using them in all good faith because they obviously were worried about the aerosol generation. But I think the thing that really protects you is your personal protective equipment and the ways that if you can, reduce the aerosol generation, which again is controversial. So if you see the two recent publications in anesthesia, they actually show that during intubation and during extubation, the high aerosol generation that we thought is actually not the case. And you must remember that these are patients who you are intubating after giving neuromuscular blockade. So it's not so much a concern, and what protects you is your personal protective equipment. So if you're well equipped, you should be fine. What is extremely important to take care is, one, you need to reduce the time of tracheal intubation, the contact time, increase the chance of first pass success. And the two things you can do to do this is, one, use the most experienced operator in your team to do the tracheal intubation, use a video laryngoscope, which serves two purposes. One is to increase the chance of first pass success. And the second is you also keep your face away from the oral cavity because you're looking at the screen. So these two things can help you. And after doing tracheal intubation, inflate the cuff first before you start mechanical ventilation. And the other very important thing is to use two HME or viral filters, one between the tracheal tube and the circuit, and the other between the expiratory limb and the mechanical ventilator. And make sure they're not just HME filters, but they're viral filters. So this is extremely important because they're different. A lot of people are just using the your routine HME filters. So these are the various precautions that you can take. But the real final barrier is your personal protective equipment. So I think you have to do what you routinely do, because the intubation boxes have shown difficulty in mechanical ventilation. They have shown tear in the PPE. They have shown a lot of cognitive overload during intubation. So what the dictum is now is to do what you're most familiar with and make sure you're adequately protected.
Which
I agree completely with Sheila. That's exactly our practice at our hospital.
Which medicine you will not give, Sheila, for induction?
So, interestingly, in ICU, we usually, because we're worried about hemodynamic collapse and these patients, maybe in septic shock and things like that, we use ketamine or etomidate. However, if you see patients with COVID-19 who come with pneumonias, they by and large hemodynamically stable. So even a bit of propofol if required. I have been started using a lot of propofol. Otherwise, I would use ketamine or etomidate unless contraindicated for all ICU intubations. So if they're hemodynamically stable and they're just hypoxic, I would even use propofol in this patient. Definitely a rapid sequence intubation, and you use neuromuscular blockade. This is very important because you don't want to do an awake intubation. And the choice would be either suxamethonium or rocuronium. And another very important thing I would like to say is that if you feel you need to do an awake intubation, please do one. A lot of people think that they should give muscle relaxant to intubate this patient to protect themselves, from the aerosol generation. But if this is an anticipated difficult airway and the risk of, losing having an airway complication exceeds the worry about aerosol generation, you should consider an awake intubation as long as you're adequately protected. So a lot of patients have had complications and morbidity because an extremely difficult intubation has been given a muscle relaxant and intubation performed in unfamiliar, not very familiar conditions. So this is currently the thinking that if you need awake, please do awake by an expert. It's not necessary to give muscle relaxant to all, but just stay protected with your personal protective equipment.
Okay, thank you. Dr. Carlos. Dr. Carlos?
Yeah.
The question is, what specific post-intubation care you will do? Post-intubation care is specific to COVID. Anything you will do? Post-intubation care.
Post-intubation, no, because
post-intubation care. Anything specific?
We only use in our ICU a mask N95 globes, and no more than that, because all the patients in our ICU are intubated and using a filter, and we need it at all. So we haven't treated during this pandemic more than 1,300 patients ventilated, mechanical ventilation. We had only 2 cases, nurses infected in our ICU. So we think that's enough.
Okay, that's great. Dr. Nitin.
Right.
Post
So,
ventilator setting.
right. Okay. I think.
So one answer. What mode you select? That's specific. Anything specific?
Can I make a comment, please, before I say anything?
Yeah, please.
I think at the start of this pandemic, we were guilty of magical thinking and forgetting everything we'd learned about lung protective ventilation. All we have done is we've gone back to everything, all the lung protective ventilation that we did in the last 20 years. We just gone back to that, and we do not do anything special from COVID apart from proning more often. So our standard mode is PSIMV. So that's pressure controlled SIMV. We aim for a tidal volume of roughly 6 minutes per kilo of ideal body weight. We measure every patient's height as they come in. We keep a peak pressure of less than 30. Respiratory rate we will adjust depending on the CO2 and the blood gases. FiO2 again, as per standard, to maintain saturations between 88 and 93, or PO2 as close to 8 as possible. Anything over 10 is definitely banned. And PEEP, again, appropriate PEEP, no PEEPs are 17. PEEP stays, we tend to start with a PEEP of 10, and then we titrate up or down depending on the inflection points. But we try and keep ventilation as simple as possible and as close to evidence-based principles as possible.
Okay, Dr. Quirino. Dr. Quirino,
yes.
your ventilator setting in COVID patient post-intubation, how you set your ventilator and what?
We have two different settings because we want to recognize patients with high compliance that they may be a little higher flow and in low compliance patients that we may force to choose a lower volume. This is important because the driving pressure will guide us to reduce the tidal volume or not. It should be considered that in obese patients, a driving pressure slightly higher than 15 centimeters of water could also be tolerated. Compliance quantity compliance quantify how many milliliters of gas enter in the lungs by increasing the airway pressure by 1 centimeter of water. In other words, the respiratory rate, if possible, limited to 20-25 by minutes. If the PCO2 rises, it's tolerated and will drop later if things go well. You will probably find more PEEP values that maintain the minimum driving pressure. Choose the lowest one, but because this allows to maintain sufficient oxygenation that we use as saturation of around 92-95%, with a FiO2 not higher than 0.5 or 0.6. Use PEEP 10 to 15 centimeter of water, which simultaneously minimizes the driving pressure and improve oxygenation, unlike other forms of RDS. Therefore, of higher PEEP than in other patients. Be patient. This is our recommendation. Use a lot of patience because this disease require a lot of time to improve the treatment for our patients.
Okay, thank you. And Dr. Levy, sir, your quick comment on ventilator setting. Dr. Mitch Levy, sir. Dr. Levy, Mitch Levy, sir.
Yeah, I'm here.
Yeah.
Yeah. So you're
Great.
asking me what my optimal settings are. I think
Yeah.
I'd have to respond by saying I really find, especially in these folks, it depends on their what their lung status is. So I often find in the beginning, these patients do not tolerate very high PEEP and are very compliant. And we have been letting these folks breathe on their own and not forcing them into 6 cc's per kilogram. When at a certain point, most of the patients wind up in more of a traditional ARDS pattern where they tolerate higher PEEP, and we go up to 18 of PEEP if we need to, and we prone them and treat them very much like we treat any other ARDS patients. So initially, we tend to be careful with PEEP because we find that they deteriorate in terms of their oxygenation very quickly, and in some cases don't tolerate it. So it really is, we find, these two phenotypes that Luciano and John Marini first identified are very true in our patients.
Okay, thank you. Pradeep Rangappa, how you set your ventilator setting?
Rajesh, see, I stick to basic principles of ventilation.
Pradeep, you are not visible.
Yeah, so Rajesh, I stick to sound basic principles of ventilation in this, keeping a close eye on the tidal volumes, Rajesh, because as all the esteemed panelists have said, because we are seeing high compliance, so you don't want high tidal volume to prevent volume trauma. And that is where we need to tweak the ventilator setting to limit your tidal volume. And I stick to the principles of sound ventilation in ARDS, with driving pressure, PEEP, optimal PEEP, and low tidal volume, plateau pressure, and all those principles apply. But I would be very sensitive to allowing higher tidal volumes in these, because we have seen that it causes perpetuating ongoing worsening lung injury. So that I would bear in mind, and I would limit my pressure support to limit inspiratory pressure support to limit the tidal volumes, and PEEP, optimal PEEP, and all the principles of good ARDS ventilation, Rajesh.
So Dr. Chawla, after optimizing optimum setting, this is what the ABG is.
Rajesh, can I just question? Now, Luciano, at the beginning of the pandemic, he came up, with these two phenotypes. I'm interested to know from Dr. Quirino about these, probably he mentioned in the group also that they've done a lot of autopsies.
Yeah.
So, what was the interesting finding which Dr. Quirino has found during these autopsies? Dr. Quirino.
Sorry?
Dr. Quirino, about your autopsy findings in these patients. I mean, you suggested that you have done a lot of autopsies.
Oh,
you
yes.
have gone.
Yes.
And, yes.
I read what we find in the lung of these patients, and we find the capillary congestion, interstitial edema, dilated alveolar ducts, hyaline membranes composed of serum proteins and condensed fibrin, loss of pneumocyte where the histological patterns of the exudative phase mostly observed in these cases. In other words, what we find also in the art, it was that a thickening of a ventricle, of the left ventricle wall of 2 centimeters, and the thickening of the wall of the right ventricle of 0.8 centimeters. The myocardium appears pale, and this justifies many sudden deaths. From an immune point of view, I can summarize that the cell of the immune system, many macrophages, but very few lymphocytes. This shows that the number of lymphocytes are important to understand the stage of the disease and intervene in the interstitium. The autopsies points
out that in the blood of these patients with a COVID-19 infection, there is a very high number of endothelial cell that is an expression of the endothelial damage caused directly by the virus. And the cell trigger a cytokine storm
Sandeep, let him finish.
recruits macrophages.
Okay, Sandeep, I'll give you his contact. Please let me finish this. Otherwise, people are now getting impatient. Please.
No, just a small thing. Did it make any suggestion to change the ventilatory settings in these patients? Your autopsy findings?
Not really.
Not really, Dr. Quirino?
Oh, yes, I can suggest one thing from our experience. For example, you talk about convalescent plasma. We start for the first in the world directly from the end of February. What is important is the timing and the dosage of what we are using. Mostly also of my colleagues in Italy are using the same drugs, the same things, but with the wrong timing. We must consider that this disease is very complicated, very quickly evolution. So if you, for example, take your patients too long in the out of the hospital with no strictly control, we have so many patients that arrives to our ICU too late. And so for this, we have a very high degree of mortality because the timing is mandatory in this disease. And what I see around the world, a lack of control of the patients that don't need immediately ICU recovery. That means that out of the hospital, there is no good strategy of our healthcare system to control strictly these patients. And when they arrive to our hospital, we say, oh, I'm sorry, we have no beds in ICU. So they need to stay out of the ICU and they died waiting the ICU beds.
Okay, sir. Thank you, Dr. Quirino, for good insight. Dr. Chawla, very quickly.
Yeah, this patient now has, if this ABG is valid, then he's got respiratory acidosis, he's hypoxemic, he's hypertensive, desaturating, diaphoretic. This patient should be nicely sedated and paralyzed because this sedation may be inappropriate. So you need to sedate and paralyze this patient and then increase the respiratory rate and probably then prone this patient.
Up to what? Respiratory rate up to what?
You can go up to 35 and then you should prone this patient as well.
Okay. So
that is what I would do.
Optimize respiratory, and even that does not work then?
Even if that does not work,
yeah,
then if you have optimized your settings, you have given the appropriate PEEP, then of course the possibility of sometimes you have to consider the ECMO in these patients.
Okay, just very specific question. I will be coming to the Rahul Pandit. What fluid you select for COVID patient? Very specific answer. What kind of fluid you give? Rahul, you are there?
If we can just feed them nasogastrically, you don't need to really give fluids. Otherwise, it doesn't matter. A little bit of fluid, just normal saline is fine, as well as Hartmann's. It's fine. Absolutely.
Anybody has any different opinion on fluid? Fluid therapy in COVID patient?
Okay. Fluid restriction as much as possible. If you are not causing a hyperperfusion, restrictive fluid policy as like for all other ARDS patients.
Is it restricted? It is restricted or balanced?
Balanced fluids.
Balanced fluids. No, the choice of the fluids is balanced. Obviously, a balanced electrolyte solution which we will be giving. But yes, after 24 hours in a patient, I will like to give him a negative.
Sumit, what do you say?
Yeah. So in this setting, I slightly different from the usual ARDS. I started with the usual ARDS protocol, trying to keep a slightly negative balance. But those patients who did not require high PEEP, who required lower PEEP, actually did better with, because they were more microthrombosis, VQ mismatch, lower PEEP requirement, better compliance. There I used a little more fluid, and that is based on also Caroline Calfee's group's work in California, where they have the two phenotypes, where they say that what is now called the L and H, the L phenotype actually giving somewhat more fluids is actually better. And I hydrated them a little more because the microthrombosis of the pulmonary vessels was cause of the problem, and hydrating them probably did better.
Okay, great. That's what I was checking. Great, Sudhir. Now, prone position.
Nitin wants to say something.
Yeah, Nitin. Yeah.
No,
Nitin.
actually, Dr. Sumit has just said exactly what I was saying.
Yeah, that's what I agree. That's why I'm not further
Yeah.
asked. I agree.
Yeah.
Nitin, very quickly coming to you. I mean, this question is to Rahul. Rahul, when you prone the patient, and how long you prone the patient?
We are pretty much, if we intubate the patient, we prone the patient. I don't wait for, so just wait for the lines to get in and, tubes to tie and X-ray to be done. And you just prone the patient. I will prone the patient for 16 hours.
Clear message,
I'm very, very clear about it. And then I don't hesitate to do 2 or 3 sessions. And each session means around 16, 17 hours of session would be one session.
Now, do you stick to 3, or you can give go up to more proning sessions?
I mean, look, it all depends on how the patient is. At the end of third session, I feel that we're almost through and he's probably going to be all right. Maybe one more session. But I think after 3, you really start doubting whether it's actually going to work or not. So if you're not having a significant improvement by the second or third session, you need to start thinking of other strategies.
Okay. Sheila, anything
we have actually.
Nitin, I'll come to you. Nitin, 1 minute. Sheila, any different strategy for proning you have? Are you follow the same what Rahul says? Sheila?
Dr. Sheila has left already.
Okay. Nitin, what are you saying?
Right. Yeah, I agree with Dr. Pandit. If the patient after intubation is on more than 50%, we just don't even wait. We just intubate them as soon as the lines are. We prone them as soon as the lines are in. But what we have had is we have had a number of patients where we've gone for 7 or 8 proning sessions as well, and they have been patients where you prone them, their oxygenation improves. You supine them, 4 hours later, they are hypoxic again. So you prone them again. And they seem only happy in the prone position. And we have had a number of patients like this, and where we have had to do 8, 9 sessions of proning. And most of them seem to actually have made a good recovery in the end. So I wouldn't limit it to 3. As long as you're having a response, go.
Yeah, that's true for us as well. We don't limit the number of proning sessions.
Yeah. That's Nitin, how long you have kept the patient in prone in one session maximum?
Okay. By mistake?
No, don't go by mistake.
Just
Evidence everybody knows. We know 16, 17 hours. How long optimum you have prone without causing any harm to the patient?
Okay. So our standard protocol is 14 to 18 hours of proning, because we often have 8, 9, 10 patients proned. So it is very difficult to be bang on 16 hours. We aim for 14 to 18 hours at the start of the day with the proning team. We just plan out what order we're going in, and sometimes it takes 5 minutes longer. So somewhere between 14 and 18 hours. We have the longest we have kept a patient prone was 24 hours, and that was because everyone was busy. We didn't have enough hands to actually deprone the patient. But we've not physically proned the patient longer than 24 hours.
Okay.
Rajesh, one comment.
Yeah, I'll come, Rahul. Dr. Levy.
Dr. Rajesh.
Yeah, Prashant, 1 minute. I want Dr. Levy to comment on proning, how long he has proned his patient for maximum.
Yeah, we stick to a very strict protocol of 18 hours prone and 8 hours on supine. And we just do it repeatedly. And
suppose you prone someone, he's maintaining good saturation, you put on supine, immediately he start desaturating. What will you do?
Well, so it depends how long. I probably, I really worry about what we see happen to people's faces. And so we've had some really bad, almost scarring with some of our patients. And so we keep them supine as long as we can, even if it means going up to 80 and 90% FiO2 to see if we can keep them on their back for at least 6 hours before we put them on their belly again.
Okay, Prashant, quickly.
I think that's where we differ. We also do it by strict protocol between 18 to 20 hours. So 20 hours is the maximum which we keep. Then we put them back on supine. What we have realized is doing good nursing care in half an hour to 1 hour. If you put them back to prone, it really helps. So we do 3 or 4 sessions or even more, but we give a gap of hardly 1 hour between the 2 prone sessions. So we do it immediately.
Rahul.
So, Rajesh, because what Dr. Arora said, we need to basically have around 7 or 8 patients, sometimes even 10 patients who are prone. We need to regimentalize it. It almost has to be like a military precision. You have a proning team which comes in and it prones all the patients one after the other. And then after 16 or 18 hours, whatever your timing is, you have the supining team which comes back and puts them supine and then comes back again. So, we've got actually a whole set of different people, 6 or 7 people who join along with the intensivist, and the head and the lead intensivist at that time who is on duty takes over the airway and the head, and everybody else sort of rallies around him and does the job. So that's how we've done.
Rahul, Rajesh, I will just quick comment. Rahul, when there are 16, 17 patients in a row, the team leader should take a decision whom to give a preference for the prone, who are getting the changes in those particular patient. If suppose somebody is elderly patient, he has a higher requirement, not having any improvement after the 2-3 sessions, what you rightly said previously, then I would not like to go ahead with the proning for that particular patient. I will see. So here the team leader plays a major role when there is a workload like a pandemic is happening and the patients are in a prone position, rather than just carried away with the 17 and 18 prones.
Absolutely, I completely agree.
Dr. Deepak? Dr. Deepak?
Yes.
When do you repeat RT-PCR in ICU patient?
Look, earlier the government directions were 14 days. Now in Haryana, it is 17 days.
Okay. Reena, what is your recommendation for repeating the test in ICU?
So we do not repeat the test. We stop isolation at 21 days. But if we find that we're in pressure of beds and a patient has been there 18, 19 days just to get that bed, we would repeat it. We would repeat an RT-PCR. And if that's negative, then we can move that patient to a non-isolation ICU bed to give that bed somebody who needs isolation ICU. But otherwise, at 21 days, we just stop the isolation without repeat.
Rahul Pandit, when do you repeat the test?
Look, at the moment, we don't repeat the test until and unless I have to actually shift this patient to a non-COVID ICU or a non-COVID area, which would be after 21 days if they still remain on the ventilator. Then I would repeat a test and shift them across.
But we don't repeat the test. We just stop their precautions and move them.
Yeah, here I would like to say one thing, if Rajesh allows me.
Yeah, please, sir, please.
So what happens if a patient dies with corona or COVID-19 positive report? Body is not given to family. In my hospital, majority of the patients are outside of the city. They are being referred from different far-flung places. So they cannot move their body to their native place. They have to cremate their patients. Like government cremates their patients in the Gurgaon only. So that is another big pressure. And we usually send when we feel that this patient is going to die and is non-salvageable. At that point of time, we usually send the COVID, irrespective of the days. It could be 5 days, it could be 20 days, it could be 10 days, just to see if they are negative, then family is free to take the body.
So Rajesh, just one thing here. Rajesh. So, Dr. Sir, 1 minute. I have a question for all of you. And it's intrigued me. Maharashtra also has the same policy of not handing over the body. Can a dead man who is not breathing be contagious?
Yes.
So, Dr. Sir, you comment and then your comment.
No. You see, there are two facets to the question. Repeating the RT-PCR. One, you have to go by the state policy and the institution's policy. There is no second answer to that. If you have a state policy or institution's policy, you have to abide by that. Otherwise, RT-PCR repetition has no clinical bearing at all whatsoever. If the patient is recovering, why repeat it? And if the patient is not recovering, otherwise also there is no clinical bearing on the patients doing RT-PCR or not. Most of the time it is being repeated because of state or the institution's policies.
Okay. And what about what Rahul has asked, that can dead man be contagious?
Yes, it has been proven.
Okay. So now I'll go to the Carlos again. Dr. Carlos. Carlos, has he left? Okay.
Left, I think.
Dr. Lopa, you're there? Dr. Lopa.
Yes, yes.
Post-COVID syndrome, one entity which has come where patient is getting prolonged sickness. He needs prolonged oxygen, coming with fibrotic lung, other complications. What are the problem you see in your setup as a post-COVID syndrome?
Yeah. The post-COVID syndrome maximum patient came to our hospital with they're with cough and they're their main problem is a psychological problem is a very frequent. But the thing is the cough is that lung fibrotic lung we get, and the patients are they get sometimes they come with chest tightness and they are suffering from low grade fever also came here. And then we sent for again HRCT, and we find that the patient has bronchiectatic change or fibrosis. So these type of patients we have some post COVID checkup also, and the routine investigations we send, and we are now adding antifibrotic to these patients, and sometimes patient come with reinfection also.
Okay, thank you. Dr. Chawla.
The post-COVID syndrome is really a big problem. I think the next decade is going to see a lot of patients with pulmonary fibrosis because, the large number of patients who have suffered all over the world, the absolute number of patients having the pulmonary fibrosis is also going to be large. Post-COVID syndrome, almost every system is involved. Dyspnea and fatigue persistent and cough persistent for a long time. Many of these patients have tachycardia, bradycardia, and now there are studies to show that there is involvement of the heart. Some people have the underlying myocarditis. So these patients can have even the conduction system abnormalities. Some people have some amount of renal derangements and liver function derangement persisting for a long time. So basically, this is a problem which have to be really followed up. And many of these patients we are finding with the persistent abnormalities, even like the persistent high biomarkers. Many of these patients have persistent high biomarkers also. And we really do not know what is the significance of them, and we are not doing anything for that. But this is a problem which we are facing now, particularly after 3 to 4 weeks of their illness.
Subal, what is the solution for post-COVID syndrome? Subal, you are there?
Yeah, I'm there. Majority of the patients are coming in with fatigue or just shortness of breath. That's the only thing. I've even seen certain patients where I've repeated scans and I've not seen any evidence of fibrosis in certain patients, and there's almost been a complete resolution of fibrosis. I've repeated CT scans in a few of my patients and also few of my relatives where there have been absolutely no evidence of fibrosis at the end of 2 months and at the end of 3 months, excepting few patients who do have fatigue or certain kind of anxiety like symptoms of reinfection. That's what is there. And certain patients do have cough or feverish kind of feeling.
Sandeep, you want to say something?
Yeah, Rajesh. Yeah, I'm a COVID survivor myself, and I can tell you that cough has been the cough and fatigue. These are the two very, very common symptoms. Which, in fact, I had cough for almost 3 to 4 months, which I had to take various antitussives and antihistaminics. Plus, I took short course of steroids as well. So that really is the problem. So
Kapil.
Kapil.
Yeah,
Dr. Rajesh.
Prasad, sorry, Rajesh.
Prasad, you want to say something?
Yeah.
Yeah.
Actually, a very important point I want to add to Dr. Chawla's point is post-COVID syndrome is not only post-COVID fibrosis. It's a multi-system disorder. So there is likely that, the patients who are sent on oxygen, please do evaluate them for BNP or a repeat echo. There is a high chances that some of these patients may have a ventricular dysfunction or a myocarditis, which is persisting. Then the other major part, which we did also with our patient, is brain fog. Many of these patients have this memory changes and cognitive disorders, and many of the reports are being, focusing on these type of psychological distress and post-traumatic stress disorder. So it's not only fibrosis which needs to be focused. There is multi-system involvement. Even acute persistent renal dysfunctions do develop in these patients, and a thorough checkup in probably in a post-COVID clinic need to be done for these patients.
Okay, Kapil, your final comment on post-COVID.
Rajesh, I have treated almost more than 4,000 COVID patients and 600 critically ill ventilated patients. And let me tell you, post-COVID is certain hype made by the medical field. Sorry for that. I don't want to comment against anyone. Generally, the most common symptoms I am coming across after 2 months is the fatigue and the cough. What Dr. Sandeep said, the dry cough and the fatigue, these two are troubling to the patient. I haven't seen a single patient of the fibrosis. I am repeating that after 2 months scan, most of time they are complaining. Now that's what the British Thoracic Society come up with the guideline of the post-COVID reporting of the X-ray and CT. They haven't talking about the only fibrosis. They are talking about the grade 0, 1, 2, 3, and very less number of patients with the fibrosis. So we need to assure through the patient that please don't much get worried about the post-COVID. This is like one of the viral infection, and might be what even Prashant said, it is a multi-systemic. It is not the only fibrosis should be bombarded on the everybody's mind. Sometimes they come with some cardiac symptoms or stroke or neurological symptoms. But one of the most commonest I came across is fatigue and the cough. These are the post-COVID symptoms.
Rina,
to add to Dr. Kapil, I think to make a diagnosis of post-COVID fibrosis, wait for 12 weeks, then only get a pulmonary function test and HRCT to make this diagnosis, because many of these changes are reversible. And after 2 to 3 months, you will not see these changes, as Dr. Chawla has also started following.
Even Prashant, after 2 months, the changes are getting clear.
Yeah,
That's what my point
exactly.
is.
So 12 weeks, at least wait for 12 weeks to declare them as a fibrosis.
Don't jump on fibrosis within 3 months or within 6 months. That's what my point.
I fully agree with you, sir.
Okay. Dr. Reena, very quickly about COVID reinfection.
Okay, so there's been a lot in the media about it, but from what we find, it's not a common thing. It's rare. There have been a few cases that are in the literature. Currently, we don't know how long the antibodies last for. So as the pandemic continues, we'll see it's going to be longer and longer the time goes. Now we believe that for 6 months, you're probably immune. It may even be longer. So it can happen, and it has happened, but it's not common. Very, very few cases that we know.
Anybody?
Yeah, can I say something?
Yeah, please, Dr. Deepak.
Yeah, recently we have 2 of our colleagues turned positive second time. One is working in intensive care unit. He is consultant. He was positive in early days of the COVID, was in home isolation, turned negative, joined back again duties. After 3 months, he again got the COVID. This time symptoms were a little severe. He had to hospitalize. Another person is one of the technicians.
Can I just add to that? I think to confirm that somebody has definitely got reinfection, you've literally got to do viral studies. You need to do sequencing to confirm that you don't have non-replicating virus that you're shedding, because that can happen. We have patients who are positive and they're negative twice, and it's positive in the early days when we used to test everybody.
Exactly, you have to do the viral cycle.
Unless you sit and do sequencing, you cannot say.
I understand, but it cannot be after 3 months with symptom.
We don't know that. So unless you do sequencing, I'm sorry, you cannot say that
I
this
don't
is.
know whether you do sequencing. We are not doing sequencing. The whole thing is patient was positive, person was positive. He was having fever, was home quarantine for 14 days, joined back duties. After 3 months, again had fever, again contacted, again tested PCR, and between 2 PCRs were negative. Now the PCR is positive. Person was requiring oxygen therapy. And those 2 were 3 months apart. Another person was a technician in ICU. Again, first time he was hospitalized with hypoxemia, was on oxygen therapy for at least 7 days, went home. After 21 days, joined back again ICU hospital. After 3 months, again got positive PCR. This time his kidneys were involved, his liver was involved, and he was in ICU for at least 10 days.
So Dr. Deepak, if you have this patient's PCR results, and I'm sure you have remnant sample, this is the samples you need to send to referral labs to see if they can do sequencing to confirm that there was reinfection. And you should do it. You should do it and write it up and say that you've got this experience. We did that. We had patients similar that we sent to our CDC here in Nairobi. and we found out it was the same virus, and they were just it was just non-replicating virus. And I think a lot of colleagues around the world have found that. So if you have these cases, please do send it.
Dr. Reena, it could be a non-replicating virus, but again, with lot of symptoms are more pronounced than previous time.
But these symptoms could be because of any other illness.
No, they could get any other illness. We tested everything.
No, Deepak, I agree with you. I have came across the 3 patients with the reinfection. 2 months back, they were positive, then negative after 14 days, and they came up with the more severe symptoms. So whenever the reinfection happened, they come up with the more symptoms, severe symptoms. Both of them survived. That is a different story. But we have came across 2-3 reinfection cases documented, which were negative after the first positive, what was the effect at that time.
Okay. So Dr. Mitch Levy, again, question to you, sir.
Yep.
Vaccine is a ray of hope or fuss?
Well, I mean, first of all, I think that we have a couple of vaccines. The Pfizer vaccine has been tested in over 40,000 patients with fairly minimal side effects. I understand people's concerns about unknown side effects when we expand 40,000 to 40 million, but it's 95% efficacy is beyond our wildest dreams. So I was asked to be first in line to get the vaccine. I got it on Monday. And I think that the vaccine is going to transform this pandemic. Now, we don't know how long the immunity will last. If it's 6 months, we're going to start to see cycles. But if it is a year, I think it will break the pandemic. And I think the biggest thing is expressing our fear in public that's unfounded is irresponsible, not just for physicians, but for politicians as well. And that's what I object to. People read the internet. We may have opinions, but we owe it to our patients and each other that if we have these concerns, unless they're sound scientifically, to keep them to ourselves.
Sumit, your comment.
So would tend to agree with Dr. Levy, but I have certain concerns that anybody who asks questions about the vaccine and it's being rushed through is kind of pointed a finger at as being an anti-vaccine lobby. That's not true. There has to be a proper scientific process of questioning, not just scientific, as I said from the beginning. The pandemic is also a sociological phenomena, and everybody, the public, has a right to ask the questions about it. And they are asking the right questions. And I'll give you the reason I'm saying is there was this side effect on a patient in India, which was suppressed, which may or may not be true. And both the vaccine company and the DCGI here kind of tried to suppress those information. And when it broke through into the newspapers, it became, I mean, there are lots of people who became very, unsure of taking the vaccine. So these are the things that governments, industry, and the regulatory bodies should look at and clarify much more before we go on from, as you said, sir, from vaccinating 44,000 people to more than 4 billion people. So those are the concerns which are absolutely genuine and which should be considered before going in for that.
I totally agree with that. But so of course, if there is any evidence of malfeasance, of inappropriate behavior, there's no question we need that uncovered. But what I'm referring to is I see it in my own hospital that people read the internet and people, supposedly reputable people, especially the politicians, spread all of these unfounded rumors that are baseless, and it scares everybody. That's very different than uncovering inappropriate behavior.
Dr. Koino, your comment on vaccine. You are not audible. You have muted yourself. Yeah.
I would like not to speak about the vaccine because my opinion, I told that. I work with the European Commission and the van der Leyen talk with the majority responsible of Pfizer and all the other company. They don't want to give us the result of their experimental trials. They are secret and they will stay secret for 4 years. I have said everything. I agree with Dr. Levy. We open a window of hope, but if we have decided after the Ebola pandemic to concentrated our money and our effort, like the WHO has decided, to find the drug against this virus, because we are changing SARS-2, SARS-3, 4, 6, and so on. So the problem will be repeated. Probably in this moment we have the right drug against the virus, and we have stopped the pandemic. Now we are in a situation that we hope that the vaccine is able to stop the contagious and stop the pandemic, but we know how many doses we can do, how long the immunity can stay, which kind of, there is no result about different genetic and genomic subject. I would like to remind to Dr. Levy, because I am sure that he knows the Obamacare point. We are talking about anecdotal result on few cases, but the base of personalized medicine is based on big data. And also in this COVID, the scientists failed completely. We are talking about small study that mostly are totally anecdotal, and in the future, for me, is just a deforestation that we forget completely. Okay, we have caused another damage to our planet. That's all. But we don't understand that if we want to reach a result, we need to put all together the result. The problem is that the scientists are jealous. They don't share the result. They want to be considered the top in the scientific world, but this is not the way to reach something useful for our citizen. So I think, and I conclude, I don't want to take more time, that if we want to help to go out from this situation, we need to push our politician on the right way. And the right ways is to collect big data. But for big data, I mean millions and millions of data, not just 1,000, 400,000 or 40,000 data. This is not enough.
Thank you. Thank you. I will not ask more question on this. Rina, what do you think how this pandemic will end? Very quick answer, because we have 5 minutes and then we wrap up. We want to wrap up.
So I'm really hoping that the vaccines work, not just the Pfizer, all of them work. And if a critical amount of people do take it, then yes, there will be immunity and the pandemic will end. But just one last thing on the vaccine. My only worry is now that FDA has authorized all these vaccines, a lot of these longitudinal studies with placebo arms, patients will drop out. And if that happens, our controls will lose our control. So that's something I think we really need to think about, and what will happen. But let's hope, by mid next year, the pandemic is over and we can get on with our lives as we did.
That's great. Prashant.
I think it's an important point. I want to use this forum as an important message. Till we are vaccinated enough to say that, we have developed herd immunity, please do not lower your guard, especially because I have already finished my 2 doses of vaccine here in UAE and my other colleagues have taken. What I see is there is a false perception of, lowering the guard, stop using the mask. Definitely, please do not do it. We really do not know whether the vaccination in the current status can actually prevent the transmission of virus to the others. Okay, so it's still unclear. You have to be very, very sure before making these statements. So please do not lower your guard. Continue to take vaccines. I believe in science. I do not want to enter that controversy, but please do not lower your guards at present.
Kapil.
Chandra, can
I'll come, Sandeep. I'm coming to it.
Rajesh, we learn a lot from this pandemic, like a self-hygiene, even self-discipline, everything. And I'm sure we'll come out with the help of the vaccine. I'm worried about what next. Are we going to get the permanent lesson in future? Otherwise, every year we'll get something, and we all will discuss such things at the end of the year. So I'm worried about the next and how to prevent that. That is my big worry.
Okay, Sandeep.
See, the thing is, I think what Dr. Dr. Levy said and Dr. Coroli said, we need more transparency of the data. I think till now only Oxford vaccine has published the full data. We are still awaiting the full data from Moderna as well as the Pfizer. As long as the full data is there with all the the evidences and everything, public will not be convinced. There'll be always a naysayer and the naysayers. So this is going to be a issue. I'm not sure how to resolve this issue. And like Prashant said, we at the forefront will take the vaccine, but the thing is, we need to go on, doing all the we need to go on taking all the precautions. So this is where my take is as far as the vaccine is concerned.
Dr. Lopa, what is your take for how this pandemic will end?
Actually, in our country, we didn't get vaccines till now, but I think we will get. But the thing is, the main thing, the people awareness is most common thing in our country, where the resource limited country. I think we should follow the thing that mask, hand washing, social distancing. This is very much important. And vaccine, if come, then we will get.
Thank you, Deepak. Dr. Deepak, your final comment, how this will end?
Nobody knows. Actually, I don't know how it will end. And I can only hope that the vaccine will work and we should not lose our guard.
Okay, thank you. Dr. Chawla, sir?
Even if the...
I come to you last. Dr. Kirino, I come to you. 1 minute. Yeah.
Even if this vaccine works, even if this disease, the pandemic finishes, this disease is going to remain as endemic. So we have to be careful in the coming many years before, really it is tested. That's what I feel, because we have to continue to take precautions.
Okay. Pradeep?
Yeah, thanks, Rajesh. So I think I'm an optimist. So I look at all the positives that India has done until now, Rajesh. So I think what India has learned is, I think we need to invest more into public health, and I think we have done good capacity building. Thanks to this pandemic, I think our district hospitals and other second tier government hospitals are more equipped now, at least in my state. It is as good as any other place that you can think of in the Western, because in one of the district hospitals, we have number of beds equal to number of ventilators in most of my district hospitals. And I think we have learned to have a good public-private partnership after this pandemic in this in India, at least. I'm sure Maharashtra has done it, Karnataka has done it, and many states have got together with good public-private partnership. And I think science is the only thing that we have to adhere to win over any disease of this, and we should not politicize. I think that's a very important lesson we have learned in this pandemic. And the most developed nations have politicized this a pandemic. I think we should get above that, and we should only subscribe to science as a matter of fact to conquer such diseases, Rajesh. So I think vaccine is a scientific aspect, so we should subscribe to it. And as everyone has said, we shouldn't let the guard down at all, because as this disease is going to be endemic, and we cannot let the guard down, because we would be threatened with more such pandemics. And we should follow the sound scientific principles in conquering such pandemics. Rajesh, over to you.
Thank you, Pradeep. Rahul, quick comment.
Look, Rajesh, 1.3 billion people, 130 crore people, 2021, we are not going to be vaccinated.
Rahul,
so don't lower the guard, is the only thing which I can say.
Okay,
yeah.
Thank you. Dr. Levy, your final comment, and then you can leave, sir.
Well, I think that this has been a wonderful discussion. I think this also illustrates the wide practice patterns, and it really illustrates how little we know about this disease. And it's why we're all so frustrated. We all believe we want to do the best for our patients, and yet look at all the difference in the way we practice. So there's enough commonality that I think we have some common views and enough difference that it's healthy. So I would just say thank you to everybody for participating, and I really enjoyed our conversation. Thank you.
Dr. Quirino, your final comment and then we wrap up. And Subal, you are there?
Just a few words, just because I discussed with your regulatory system, because the chief, I know that the Indian have his own regulatory system for the approval of the drugs. You don't follow anymore FDA. FDA in USA and the MEA are the regulatory organization to protect the citizen from the side effects of the drugs. How they work, this we must know, otherwise we can have a wrong opinion. The lobby of the big pharma is so strong. If you go to Brussels or to Washington, you find always during the corridor the big pharma representative. And what is important to know that there is not a separation between regulatory and big pharma, but they are still in the same commission. And the more, for example, in FDA, I went many times to FDA discussion, they more money they give, more speedy is the approval. And you need to consider that Pfizer is the main important financial for the president campaign. The same in Europe. We have the same problem. There is no separation. So you cannot be sure of the result of their approval or no or denied.
Thank you. Dr. Subal, your final comment and then we wrap up.
Yeah, nothing, Rajesh. I agree with all. Don't lose your guard and hope that everybody gets vaccinated. That's all.
Subal, Rahul, I stopped in between because Dr. Levy was leaving. Your comment, final comment, Rahul.
No, myself, it's not different than what I said, Rajesh. I only want to say 2021 is going to be exactly the same as 2020 for us in terms of personal protection as well as our family and friends protection. So continue the same. That's all.
Thank you. Thank you, everybody. And thank you for joining